Good afternoon, and thank you for joining our Utilization Management Roundtable on the Centers for Medicare and Medicaid Services, Interoperability, and Prior Authorization Final Rule. I am Deneen Saccone, Vice President of Policy and Advocacy at Cancer Support Community. Before we begin, there are just a few housekeeping items. Today's webinar is being recorded and will be available for viewing afterwards. An email will be shared in the coming days with all of our registered attendees as well. And if you have any technical or administrative difficulties, please let us know by using the chat box at the bottom of the screen, and we will do our best to address them. Please submit questions via the Q&A box throughout the discussion, and we will do our best to get to them during today's Q&A portion. This roundtable is part of Cancer Support Community's Forum on Utilization Management. Now in its sixth year, the forum was created to do three things: foster thoughtful discussions that engage a broad range of healthcare stakeholders and keep the focus on patients, ask tough and nuanced questions about when various utilization management approaches are acceptable and when they have the potential to harm patient health outcomes, as well as identify new ideas and promising practices that optimize evidence-based healthcare. Utilization management strategies are common policies which, when implemented appropriately in the healthcare system, can enhance the patient experience and improve quality of care. However, they also can negatively impact patient access to care and contribute to provider burden. Since 2019, Cancer Support Community has hosted quarterly roundtables on critical policies. I want to take a moment to thank our sponsor, Novartis, for helping us to facilitate this important dialogue. Cancer Support Community is committed to fostering conversations that inform and engage all stakeholders in the creation and implementation of utilization management strategies that include the patient perspective and incentivize cost efficiency through improved patient care and outcomes. We are all here today because we believe that we have a role to play in making high-quality healthcare accessible to all. Before we begin, I would like to take a moment to acknowledge Cancer Support Community CEO, Sally Werner, to share a few opening thoughts.
Hi, everyone, and thanks, Deneen. Thank you to everyone joining us today for this important discussion on prior authorization. We are looking forward to what we believe will be an engaging and informative discussion about the Centers for Medicare and Medicaid Services finalized policies aimed at reducing the burden of prior authorization on patients in the Interoperability and Prior Authorization Final Rule. CSE is a proud leader in patient advocacy and ensuring that the voice of patients, caregivers, and survivors play a central role in policymaking and implementation. We began this forum on utilization management, now in its sixth year, to inform and engage stakeholders on issues that directly impact patients and the cancer community that we serve. I would like to again reiterate our appreciation for Novartis for making today's roundtable and our continued work on this utilization management space available and possible. No matter where your knowledge of prior authorization in this final rule lies, we are grateful for your participation today for what we expect to be a very educational and insightful conversation on the current landscape of prior auth, its effect on patients and provider communities, and what we as advocates can do to ensure that patients remain at the center of their own care.
Thank you, Sally. So we're going to put up a polling question. We have a polling question for the group before we begin. What do you hope to get out of this session? We'll give you some time to answer the poll. Looks like responses are slowing down. So I will share results. So it looks like everyone, the majority of attendees are interested in getting an update on federal policy initiatives. So this is the right webinar. So with that, we can go ahead and move over to some presenting slides I'd like to share before we begin the conversation. Wonderful. So today's agenda, what I would like to do before we get started is give a quick overview of some of the main takeaways from the CMS interoperability and prior authorization final rule that have an impact on patients that I think would be of interest to you all and help frame the conversation. So we all know what prior authorization is primarily. So sometimes referred to as pre-cert or pre-auth. It's a process that requires healthcare providers to get advanced approval from a health plan before a specific service is delivered to the patient to qualify for payment coverage. What we do know is that inappropriate utilization of prior authorization can have impact on patients' access to care and services in the following ways. It can delay access to necessary care. It can worsen outcomes and increase emergency needs due to the delayed access to necessary care. It can also disrupt treatment plans that have been made between the patient and the provider, particularly if the health plan opts not to offer prior authorization or provide prior authorization for the medically necessary services that were prescribed by the physician. And it can also add increased administrative burdens to the physician, the provider, and their practice that challenge time spent on patient care. And so the CMS interoperability and prior authorization final rule that came out in January of this year aims to address some of those barriers that I talked about in the last slide. And CMS, the Centers for Medicare and Medicaid Services, plans to do that in the following ways through this rule. This rule has established requirements to improve the prior authorization process through policies and technology to enhance communication between patients, physicians, and payers. Now, not all payers, not every single payer or commercial insurer is impacted by this rule. Here are the types of health plans that are Medicare Advantage organizations, state Medicaid and children's health insurance program agencies, Medicaid managed care plans, and CHIP managed care plans, and qualified health plan issuers on the federally facilitated exchange if they don't apply for an exception. So generally, this would apply to qualified health plans as well, unless they say that they need an exception to this rule because of burden or cost. And or CMS rather approved that exception because they don't want these rules or the requirements to discourage health plans from offering qualified health plans on the exchange. And so the goal of today's webinar is to help patient advocacy groups understand how this rule aims to reduce the burdens of prior authorization on patients and providers to improve timely access to care. And so how does the rule aim to do that? Advancing interoperability and improving the process, increasing patient, provider, and payer access to patient health data through interoperability, reducing administrative burdens, and by doing all of these three things, they aim to improve access to care for patients. One thing I would like to highlight is that this rule does not address improvements to the to the prior authorization processes for prescription drugs. CMS has said that this rule does not address that at this time, and that that's an area they may consider in future rulemaking. And so a few of the key changes that I'd like to go over relate to enhancing transparency. These requirements go into effect starting in January of 2027, and some of the ways in which CMS aims to enhance transparency to prior authorization information for patients is through a patient access API or an application programming interface. But for all intents and purposes, I look at that as an electronic portal. Essentially, what CMS believes is that if patients are incentivized to have access to their data through a portal, it will be easier for them to follow and have access to their information. And they're also requiring that by 2027, impacted payers, the ones I mentioned on the first or second slide, they have to also provide education to patients and providers about the benefits of engaging in a provider API, for example. So if you're a patient, they say an impacted payer has to explain to a patient, here's why it makes sense and it might be advantageous for you to allow your provider to share information with you, the patient, and to also share information with us, the payer. And you have the option as the patient to opt out of that provider API. But the payer API as well, which is again that application programming interface, that would allow health plans to share information with each other, because CMS understands that one patient may not have one payer throughout their entire care journey. And so again, to kind of help with that care coordination and that information sharing, they're saying that, patients can opt in to allow payers to share their information. Another key change we'd like to share is ensuring timely decisions to prior authorization requests. And this requirement goes into effect in January 2026. Prior authorization decision timeframes for standard requests have been shortened to 7 calendar days from 14 calendar days, and expedited requests have to be decided within 72 hours, and an impacted payer has to provide a specific reason for a denial of an item or service. Other changes are impacted payers have to develop or make available what they call a prior authorization portal in January of 2027. And this prior authorization portal has to provide whether an item or service requires prior authorization, what are the documentation required for those prior authorization requests, and it has to also allow providers to be able to share information related to that prior authorization request with payers. And there is also another requirement to enhance transparency related to requiring impacted payers to publicly report on their website starting in March 31st, 2026, certain metrics about their prior authorization process. And we'll go into that quickly on the next slide. And so just to give a little bit of detail to some of these changes that we talked about, when we talked about enhancing transparency, what does that mean for a patient? That means that starting in 2026, 2027, payers have to provide a specific reason for why the prior authorization request was denied to the patient through that patient API that I talked about earlier. However, the impacted payer does not have to share the clinical criteria used for that prior authorization decision with patients. When it comes to ensuring timely decisions, as I mentioned earlier, payers have to complete normal requests within 7 calendar days, urgent requests within 72 hours. However, the standard request does not apply to qualified health plans. CMS decided that 15 calendar days, or 15 days rather, for qualified health plans for a standard decision was sufficient. And there was a lot of comment in the rulemaking process to allow for or require real-time real-time authorization requirement determinations. They're not requiring that at that time, but they said that potentially in future rulemaking, they will. And so I mentioned that there are some required public reporting requirements of prior authorization metrics beginning March 31st, 2026. And here they are. Impacted payers must publicly report annually beginning March 31st on 2026 on these metrics. I'm not going to read them all to you, but it's again in the spirit of enhancing transparency. And so that payers can kind of have a sense, and others as well as patients, of how they do with respect to prior authorization requests. Examples include, what are the items and services that require prior auth? What's the percentage of standard requests that were approved, denied, timeframe extended, and you can read the slide for yourself for additional information. And we will be sharing these slides at the end of the webinar. And so with that, I did want to also share that there is additional information you can refer to from the CMS website related to a fact sheet and a web page that kind of has a lot of great resources and information if you want to get into more detail with respect to the rule. So I also leave here our email address if you have any questions related to areas in this slide that I went over. Be happy to answer those questions. So with that, I would like to begin our conversation, and it is my honor to acknowledge the esteemed panel of experts on utilization management and prior authorization here with us today. And I would like to allow them to introduce themselves. So I would like to start with how we see them on the slide. If we could start with Anna, and then Dr. Parvati, and then Peggy. Thank you.
Hi, everyone. My name is Anna Hyde. I'm with the Arthritis Foundation. I lead our government affairs team here at the AF, a longtime partner with the cancer support community and many of you, and glad to be here.
Thank you. Dr. Parvati.
Good afternoon, everyone. Great to be here. I am a radiation oncologist in practice, chief of radiation oncology at Kettering Health in Ohio, and I am the chair of the Payer Relations Committee at ASTRO, which is part of our health policy arm of the American Society of Radiation Oncology, which is ASTRO.
Wonderful. Thank you. Peggy?
Hi, I'm Peggy Ty, and I'm a principal at Powers Law, and I have the honor and privilege and a lot of work that comes with running the Regulatory Relief Coalition, and we're the coalition that's advancing the leading bill on prior authorization reform in Congress.
Thank you. So I think we can begin our discussions. I'm really excited to have this conversation. So I'd like to open it up to you, Dr. Parvati, and kind of talk to us about how prior authorization in your experience is operating currently, the current landscape. We know that CMS through this rule is attempting to address a lot of those common concerns about prior auth, but would you mind sharing with the group, as a radiation oncologist, what does prior authorization mean to you and your patients? And have you seen this policy cause worsen outcomes for patients in your practice?
Thank you for that question. So I would start off by saying there's or maybe asking is kind of a rhetorical question, is what does traditional Medicare and what does the emergency department have in common? They have in common that those are environments where there's no prior authorization. And so if we think about prior authorization and how it impacts some of our most vulnerable patients, it impacts them in a way that the natural history of a lot of their conditions are that they finally get addressed when their care has been denied and they ultimately end up in the emergency department. And I see it all the time. In fact, I just saw a patient today who had a lung nodule, and it was discovered 8-9 months ago on a CT scan when they presented to the ED. And then they were supposed to follow up and have another CT scan as an outpatient. But this is a patient who's got various challenges, various social determinants of health that are against them. And when that second scan was ordered, it was denied. So unfortunately, months go on, and now they present to the emergency room again with pain, with weight loss, other symptoms, and now they have metastatic lung cancer. So what was presumably a highly treatable cancer was not treated because they did not have a follow-up scan. The original scan was sort of an indeterminate nodule, and now they're presenting in this situation where they're obviously not curable and they have to face morbidity and ultimately mortality from this condition. And there's plenty of other scenarios that are common as well. And if you talk to emergency room doctors, they're the ones who really know. And I hear this from my colleagues all the time. They don't have a single shift where at some point during a patient's journey that they're seeing during their shift that a patient wasn't impacted by prior authorization. So it impacts outcomes. There's enormous cost to this. There's estimates that $60 million is spent on prior authorization just for Medicare Advantage. So 35 million prior auth requests a year, costing about 60 million just for the initial request of the prior authorization. So it impacts patients, and it also impacts practices from the standpoint that we're spending money on all of the work that has to be required to sort of service the prior authorization requirements.
Yeah, definitely. Thank you. Anna, I'd like to ask you from a patient advocate perspective, what does prior authorization mean to your patients and their community?
Sure. So arthritis is an umbrella of over 100 different diseases, but we'll focus in, I think, for this purpose, let's just take rheumatoid arthritis as an example. It is a disease that for many patients requires biologic medications, which are expensive and therefore are subject to utilization management practices at a higher rate than many therapeutic areas. So prior auth is certainly part of that. We did a survey last year trying to understand better what the prior auth experience is like for patients, not just what impact have you had from it and have you ever had a prior auth, but how often have you had to go through prior auth? At what point during your disease journey did you have to go through prior auth? And it yielded some really interesting insights. I'll just go through a handful here. The kind of top line is that many patients, over 88%, have experienced prior auth in the last 5 years. That's not necessarily a bad thing. Prior auth certainly has a role. And for many of those patients, there was no issue and the prior auth was streamlined and they got the medicine they needed when they needed it. However, we do know that delays are also common and have led to a lot of negative impacts. So, what we sort of heard as an umbrella kind of statement is that delays in getting prescription medications because of denials or delays in the process or whatever it may be has led to significant negative impacts physically, socially, emotionally. We certainly have heard from patients who developed anxiety disorders and sort of mental health issues as a result of having to deal with the administrative burden of going through prior auth and other utilization management techniques. The results physically, certainly worse joint damage is a common one. And that leads to inability to participate in normal activities, including work. So there's an employee productivity aspect as well. A couple of other just quick stats. I already mentioned that a number of our patients have had to go through prior auth. In the vast majority of the cases, the PA is approved. Doesn't necessarily mean it's approved timely. We hope that most of the time it is, but that's not always the case. Of those for whom it wasn't approved, 43% of respondents appealed and the PA was not granted. So that's an alarming number. What's going on there? That almost half of patients who are appealing are being denied. 28% didn't appeal. And there's also a lot of sub questions in there. Why was that the case? Did they not know about the appeal process or was there something else going on there? And then 28% appealed and it was granted. So, that's the good news. When the appeal was denied, we really wanted to dig into that. 35% used a different medication as sort of a follow-up, like, what did you do? You were denied. 35% use a different medication, 20% didn't use the medication for a long time. In some cases, that can be months or even years. We've heard it's taken patients to get back onto the therapy that they need. And then I'll end with just an anecdote that one of our patients used in a panel last year that we hosted on this topic that really has stuck with me. He said that prior auth is my hurricane. So when you're experiencing, you live in a hurricane zone and there's a hurricane, you stockpile, right? You stockpile water, batteries, whatever else that you may need to get through it. He feels that way about prior auth. He knows that every year he's going to have to go through prior auth with the same medication, and there are going to be bumps in the road and delays. And therefore, if I'm able to stockpile my medications ahead of time, I can get through that gap in time without having a complete sort of absence of treatment. So to me, that's become kind of my North Star when thinking about prior auth and streamlining it.
Yeah, it's, stockpiling. It's unfortunate that that's how that patient felt, that they had to kind of navigate the system. They should kind of have that confidence, right? In knowing that when I need medically necessary and appropriate care, I can get it at the time without unnecessary burdens and hurdles. And so what I would like to do, I just did a few slides kind of talking about some of the changes CMS has finalized in response to, some of these burdens and concerns that Dr. Parvati and Anna just mentioned. What I would like to do is ask Peggy, starting with you, for your reaction to those recently finalized changes in the CMS rule that we know, go into effect. Some start in 2026, some start in 2027. I'd like to ask you, what role do you think the recent final rule will play in decreasing some of these burdens that they just explained and the opacity of some of the PA processes in the longer term?
Right. Well, let's start from where those rules came from. So about 6 or 7 years ago, a group of us got together, medical specialties primarily, and said, we've had it up to here with prior authorization. It just gets worse and worse and worse. And then we went and looked at the law, and the law on Medicare Advantage was really clear that you were supposed to be giving services to people in a timely fashion. So from that came the bill, and that was the first bill, the Improving Seniors Timely Access to Care Act. That bill's gone through some modest iterations over the years, but we were the ones who really propelled through that bill language, the agency to act. So if you look at the bill compared to the rule, and actually 3 rules, you'll see a lot of the work in the bill language that was borrowed and happily borrowed by the administration. So what it really means, and trying not to be too pithy here, is the difference between 16 billion and $4 billion, and the ability to pass a bill into law. So the fact that the administration acted on the bill that we had been advancing and gathered a tremendous amount of support to the tune of over 500 endorsing organizations last year, and hundreds of members of Congress last year, that was only stopped by the Congressional Budget Office because they tagged it with a $16 billion score. The fact that the agency acted dropped that $16 billion score to $4 billion. $4 billion is still obscene in this Congress, right? It's hard to pass anything that costs anything. This Congress has been, well, beleaguered by an inability to pass anything. The bipartisan nature, I think, is probably gone. It's a frustrating time. We're in an election year, and they passed a whopping 27 bills. I think this bill has a more than a shot of moving this year because of the new draft of the bill that is now circulating, and a conversation that's going to happen tomorrow with the Congressional Budget Office. If the Hill staffers made the right changes to the bill, the Congressional Budget Office, we hope, will come back and say it's a 0 score.
Wow.
If they come back and say it's a 0 score or a really minimal score, that bill could pass in this Congress, in the House and the Senate. This very beleaguered Congress could actually pass that bill because of all the support we have on it, and because of what the administration did with the rules. So I'm really hopeful that we've got the best shot we've ever got, and it's time to move towards a system that's far more transparent, that is holding the insurance industry accountable for the decisions that they've been making that have been delaying and denying care to people who physicians and nurse practitioners and others have been recommending people have because it's necessary, not for kicks, but it's necessary. And when we're talking about cancer or rheumatoid arthritis, chronic conditions, deadly conditions, there is no excuse in my mind that we continue as a country to allow these Medicare Advantage plans to keep preventing people from getting care.
Absolutely. So I have to ask, what you're comfortable sharing. The new bill, I have 2 follow-up questions. The new bill that may be released tomorrow, is that bill specific to Medicare Advantage, or does it expand to other impacted payers?
Medicare Advantage only,
Okay.
but we think it's a fabulous camel's nose under the tent to other payers. We'll talk about this, I think, a bit later, but even states are starting to act on this. And there are some other bills floating around that could tackle the ERISA market. And that is a huge leap for the federal government to actually contemplate going into a marketplace that the federal government doesn't like to touch. They like to leave that up to the states. So this bill, I think, is snowballing in a great way to broaden out to many more populations, not just Medicare Advantage, which is another way of talking about Medicare Advantage. It's the managed care version of Medicare fee-for-service.
Right. This is exciting, and I am anxiously awaiting that information tomorrow. I had one more question that really caught my ear. You said that the original bill had over 500 endorsing organizations. So when I hear that, that sounds very much like there's a lot of diverse stakeholder support. Does that extend to payers as well?
Interestingly enough, it does. So the Better Medicare Alliance, we were able to convince them through a lot of hard work that they needed to support the bill. So we also understand, as of yesterday, I heard that United and Humana have told the Hill staffers that they are in full support of the bill.
Amazing.
That's pretty amazing, right? Now, what
Yes.
we did was carefully calculated to make sure we kind of put them in a box. How
Mhm.
could they be against providing the thing that we're paying them to provide, right? And
Right.
all we're asking for is transparency. We're not giving a mandate that they can't use prior authorization. I wish we could tell them we couldn't use prior authorization, but I know that's a bill that would never have passed Congress. So we carefully crafted, strategically crafted, again, that Campbell's nose under the tent to get this door open, to take the right direction for healthcare policy, which is we need to know what's in the black box. The good doctor doesn't need to go in and say, well, what are you covering and not covering every stinking time he's taking care of a patient. He should know up front. What are your rules on prior authorization? What are you going to approve? What are you not going to approve? It should not be the game playing anymore. And that's what the bill and the rule are intending to do. And
Absolutely.
the other element of the bill I can't forget, and of the rule, is a new system for electronic exchange of that information. That's critical. It's a
Yes.
critical part of it. The bill and the rule handle those things a little differently, and we'll see how that all works out in the wash. But the sharing of information between patients and providers and insurance companies, we've been doing it poorly for years, and we need to open up that process as well.
Absolutely. Couldn't agree more. So Dr. Parvati, kind of hearing, some of the recent activity that's been, happening legislatively. And also, like I said, the overview I gave about some of those changes in the CMS rule. Can you speak to some of those changes in the CMS rule from a physician perspective, specifically the aspects of the rule that you think how they will translate into your work and
Sure.
practice?
Yeah, so not only in your introductory presentation, but in Peggy's comments just a moment ago, you really hit on a lot of things that are quite relevant to our daily work. And so I'll try to make them even a little more concrete. So the standardization of data exchange. So that's huge because when you go through prior authorization with some of the third-party benefits managers, and they agree to authorize your request, or maybe you did a so-called peer-to-peer, where I talk to a physician who works for the third-party benefit manager. They provide authorization. They provide an authorization number, but there's no standard communication and no paper trail or electronic trail, if you like, of what's actually been prior authorized. So the CPT codes that have been authorized there, no one really knows what they are. We know what we requested, but we get nothing back in a standardized way from them saying, yes, CPT code 1 through 10, we've approved them all. Another one is the standardization of data exchange and the transparency piece. So if we, often what happens is we send a request to either to a payer or a third-party benefits manager, and then some of them, let's say the real egregious ones, they play this game where, oh, we didn't receive it, oh, you sent it the wrong way. No, it has to be crystal clear, standardized way that the data move between us so that there's accountability as to who last, received contact, a two-way authentication that data was sent correctly and received correctly. So that would be huge to eliminate delays that come just from those games that are played. The reduced timeframes are obviously important. So you're talking about cancer. I mean, I do my best. My department does our best to see patients, within a week of when they're referred to us. And that's great. That's reassuring to the patient. But that advantage that the patient has by us seeing them quickly could be negated by a prolonged prior authorization process. I mean, 2 weeks to get authorization for a plan of care for a cancer patient, as is currently the situation, which will be changed to a week, I guess, for non-urgent cases. That's a big improvement. And then, all the integration as it relates to the EHR integration. So being able to have less contact, staff spending less time filling things out, writing them by hand, but having this smoothly integrated into the electronic medical record through the electronic PA aspect of this would be also greatly beneficial to department operations and again, benefit patients as well.
Thank you. And Anna, would love to hear how could you discuss a little bit how you believe this rule may impact patients? And if you see, there are these benefits where it may impact patients, do you still see an opportunity where the rule could be strengthened in the future related to patient access to care?
Sure. I think the transparency piece is huge because patients often spend a lot of time triangulating between the pharmacy, the provider, the payer to try to figure out where the prior auth is in the process, what more information is needed, and that sort of thing. I mean, hours and hours and hours is not uncommon for us to hear from patients. And so I think having more streamlined sort of ability to access that data, where is the prior auth in the process, is huge for helping the patient triangulate on the administrative side. But I think the other pieces are really important too. The payer-to-payer, provider-facing APIs, not just the patient API, because that helps to build that continuity of care, that record that in theory should follow the patient. It sort of helps to enable our philosophy of, healthcare should follow the patients rather than patients always having to follow the healthcare. So it really opens the door for that, and we're really hoping that the stakeholders will be, compliant. I think there are a couple of missing pieces. The big one is prescription drugs. The rule does not apply to prescription drugs. That's a separate pathway according to CMS. Although I think a lot of the community, including us, see it differently and have really urged CMS to follow up with further rulemaking on prescription drugs, because that's where the majority of prior auths are seen in our patient population. So that's one piece. I think there's another piece. It's not necessarily a policy piece that's missing, but I do think there's an educational component that's going to be really important. There are patient-facing APIs available now to patients. Most patients aren't aware of what that is, or that it is something that they can have access to. I think an effort to really help patients to understand what tools are available to them that can help them navigate the just healthcare process is going to be a really important component as some of these pieces come into play and start to get implemented over the next few years.
Great. So when we talk about education, particularly from a patient perspective, so CMS is saying that impacted payers have to educate, right? And they can opt out of the provider API, but they would have to opt in to the payer API. Do you think that opt-in, opt-out could have an impact on uptake or utilization by patients? And do you think that there's also a role that patient advocacy organizations can play also with respect to educating patients about the benefit of the data exchange function, the APIs?
I do. I think that historically the difference between opt-in and opt-out really does matter a lot. This is something we're navigating right now with some other Medicare rules. But for this, I think, we're hoping that there is just a general sense of kind of goodwill to be compliant with the pieces that are opt-in. Certainly, we'll be doing our part from an advocacy perspective to drive that forward. I think there's a big role for patient advocacy organizations to educate patients, and we certainly will do our part in that. However, I think, our reach is only so big, and so it does require kind of a multi-stakeholder effort. I think there's also a big role for provider offices to play. I always say that because no matter what the subject matter is that we're talking about, because the provider is the most trusted source of information to patients. We find that over and over again in surveys and focus groups that we do, but also because they have the most regular contact with patients and the broadest sort of reach within the patient community. So what I'm hoping is that we can all kind of work in concert together, particularly within, our respective therapeutic areas, to make sure that we're targeting the right, kind of messaging and things like that.
Yeah, absolutely. I agree. I think do not disagree with that. And also this is one opportunity for alignment within the patient advocacy community on education and outreach, in addition to, which we're not discussing in this webinar, but the Medicare prescription payment plan as well, right? That's
that is
another
the one I was
area.
talking about.
Yeah, where we know our role there in educating and getting the word out is so important. So you're absolutely right. There are these important changes that are coming by Medicare, a Medicare Advantage for this and others, but patients have to know that they're out there and they have to know it's important. And I agree, it is a multi-pronged approach. It's patient advocacy groups, it's the provider community, it's the impacted payers, and other stakeholders as well. So I definitely agree on that. So I don't want to be the Debbie Downer, and it's not to put you on the spot, but given your commitment to, patient advocacy and the work you've done throughout the years, is there something in the rule? I know we mentioned prescription drugs. Is there anything else where you feel like CMS could try to further improve patient access, or do you think this is a pretty decent first shot?
I think this is a really decent first shot. There's a lot in there, and if you read through it, they say a lot of the right things. So I think, and I'm all about sort of thinking about things comprehensively but incrementally at the same time, if that makes any sense. I think we all have ideas about what perfect looks like, but getting there to all of the reasons Peggy was talking about earlier, in addition to many other reasons, is really not feasible. And I think we're thinking about it differently now. Let's start here, put this into place, make sure it's working well, and then build upon it. I do think that things like addressing prescription drugs need to happen in parallel. That's not something to build upon, that's something to do now. But I think that this goes a long way towards achieving a lot of what we have identified as challenges for patients. We certainly would love to see shorter timeframes even and things like that. But again, I think we're really happy to see this commitment by the administration, and to see how it unfolds.
Wonderful. Yeah.
Do you mind if I jump in here?
Yeah, absolutely. Please.
I think
Only if you agree with what I just said.
which I absolutely do. We're thinking along the same lines of how do we expand this going forward, because this is a really good first start. But what I want people to understand is that when you have a rule, that's nice and a wonderful thing, but unless it's codified by law, it doesn't have the same force and effect. So somebody said to me, well, you got a rule, you're good, you can just put your toys away and whatever and stop fighting this fight. Oh no, we have a really long road ahead of us. One is codify as much as we can of the rules into law. Number two is protect them. Who knows, the next couple administrations come in and somebody tries to undermine the regulatory process that's doing the stuff we like. We're going to have to keep fighting and make sure that just fighting to hold on to what we've got, plus then trying to add other things going forward. So it's a process, and it's unfortunately a long process. It's just the way the federal government and regulation and law works. But we've got to remain vigilant that this is the right direction for our country to go with prior authorization, which I believe has absolutely run amok.
Yeah, and I'm glad you said that. I'm glad you made that important distinction for our listeners about, regulatory advocacy. Regulations are great, but administrations change and priorities can change. But if you codify something, that it's codified, and it's a heck of a lot harder to change. And that's why, when Peggy mentioned that there's this new bill coming out to kind of build on this, that could bring the score down to 0, I got really excited because that's huge. And I just want to make sure that our listeners are aware of the real potential and promise and momentum that could be behind a bill that has a 0 score or a near 0 score. So thank you, Peggy, for adding that additional context that I think is really important. What I would like to do a little bit now is shift gears. We talked about what's going on at the federal level, and we mentioned a little bit that there's a lot of state movement going on. So I'd like to talk about some state approaches related to prior auth. And one concept I'd like to dig into a little bit is gold carding. So for those who aren't aware, gold carding is essentially an exemption that a provider will get to prior authorization of a health plan. And what that means is that the physician or provider is exempt from the health plan's prior authorization requirements if certain metrics are met. Say, for example, if within a 6 or 12-month time period, that physician or provider had a 90% physician approval, they can be exempt, or gold carded rather, from that health plan's prior authorization requirements. And so we know Texas implemented this law, and there's other activities happening at the state. So what I'd like to do is ask you, Dr. Parvati, starting with you. We know that, like I said, Texas has implemented the gold carding laws, and other states are really interested in doing that as well to improve timeliness to care for patients and address some of those burdens we talked about, particularly the administrative burdens for the physician and or their practice. Do you think this word always gets me, gold card laws are meaningful regardless of physician specialty? Or do you think that there should be certain considerations for services provided by physicians who primarily treat people impacted by cancer?
That's an interesting question, and it's certainly very interesting to see all this movement at the state level on various items as it relates to prior authorization, gold carding, most interesting potentially among them. So we know that prior authorization and the burden of prior authorization doesn't really equally fall on all areas of care or all specialties. And so the whole relevance of gold carding by extension is going to be more or less depending on how much prior authorization that is necessary to take care of the patients in a given, with given conditions, let's say. So in oncology, we know it's a huge deal, whether it's radiation oncology or medical oncology. And so what I would say is that if we're interested in the idea of special consideration given to certain specialties, I would say in oncology, the complexity is very high, and it's not unusual that we use treatments that are evidence-based, but are still off-label uses. Off-label uses for, by that, I mean, we're using a given medication in a way that doesn't have an FDA indication, or may not be on the NCCN guidelines, which is kind of our, Bible in oncology, that usually we see close agreement between what's in the guidelines and what prior authorization allows, but not always. And so if you have providers or, departments, institutions that have a high, or individual physicians who have a very high rate of approval for the services that they offer, it probably makes sense to get out of the way and gold card those folks so that they can get their patients onto treatments that might be off-label uses or might be, off pathway. Let's say that's another way that's just described. And in cancer, that's pretty much a routine situation, a weekly occurrence. And so that's what I would say, is that gold carding does have substantial value in the oncology realm. It probably has less value in some others. And what I just talked about in terms of off-label and complex sort of end of pathway or off pathway treatment approaches are a reason why it's particularly relevant in oncology.
Thank you for that. Anna, would love to hear from you if you think there are any other specific considerations in addition to the ones that Dr. Parvati mentioned that should be taken into account to improve patient access.
Sure. I basically agree with everything he said. And some of my remarks were going to follow suit on the gold carding piece. I do think, the way gold carding is done does need to be looked at differently for different specialties, because it may be that, you are doing a prescription for a patient just once a year, or it could be that you're writing a prescription for a patient once every 3 months. And so what is that time frame that's going to sort of follow the physician in that case? So that's kind of one consideration that I would certainly urge legislators to look at who are considering this kind of approach. I think it's also important to caution, I'm channeling the AMA here, against thinking about gold carding as a catch-all solution. It's one step in a broader set of needs to streamline prior auth. So I think that's another piece, just a broad consideration. I do think that a lot of chronic diseases, certainly inflammatory, autoimmune diseases like rheumatoid arthritis I mentioned earlier, are very heterogeneous. I get this. This is your gold carding is my heterogeneous. Let's just pretend that I said that correctly and move on. So there's a lot of differentiation among patients. And so whether it's a patient who needs a drug off label, or oftentimes they need a different dosage, that will trigger a prior auth and a denial. There needs to be more flexibility in the system overall to allow for that gray area. I think that's where we're seeing a lot of our patients falling through the cracks, and the people who are having to go through the prior auth battles for months at a time, it's often because of things like that. So I want to spend more time focusing on how to protect patients who sit in that gray area. And it's something that we're talking about more to different stakeholders. The only other piece I would say, this is more of a process consideration, is just there need to be more standardized and structured ways for patients to be involved in formulary decisions. These are also conversations we're having with various stakeholders, but ways for patients to be involved in P&T committees or other formulary decision-making bodies, so that patient perspective and those sort of gray areas that I mentioned can be brought forward, and just create more context and situational awareness for payers who are making decisions about prior auth.
I think that's great. And I think gray area may be more common than payers may want to accept or acknowledge, because we are individuals, right? And so we have different needs. We may react differently to treatment, a medication. And so absolutely, I love that you said that you're focusing in on the gray area. So I'm going to steal that. I think that's actually a really good way to frame it. So what I would like to do in the little bit of time we have left is talk about the growing use of algorithms in prior authorization and utilization management, right? So we know earlier this year, CMS, I believe back in February, they released an FAQ to health plan, Medicare Advantage plans, an FAQ regarding the use of algorithms, where they essentially clarified that algorithms may be used only if they assist in with respect to, regulatory requirements for coverage, but they have to make sure that those decisions are on a patient's individualized circumstances and not just using that if then metric, so to speak. So Peggy, do you think, I want to bring you back in, increasing transparency on the prior authorization algorithms and metrics that payers use to approve or deny requests provide meaningful benefit?
Yeah, and I think, and that's why it got put in our bill and ended up in the rule as well, is that there was a hue and cry from the patient community, go patient community, that said we got denied, and when we found out how we got denied, we were disgusted. And it was because an algorithm said, well, that's a high cost. That's a high cost. There's a lot of those services. So the insurance companies used an algorithm I could have written, and I can't write algorithms, to just say high cost and frequent, utilization. And that's obscene to me. And I don't even have a medical degree. That's how we're making decisions about people's healthcare. So that is why you can't ban all use of AI, for example, artificial intelligence, nor should we, I don't think. But when it comes to prior authorization, decision making, clinical, medical decision making, it has to be tempered. So the transparency of it that is required by the bill and by the rule, I think would go a long way, because the optics are terrible for the insurance industry. New York Times stories right, left, and sideways you'd see before they stop that practice. So I think transparency will bring the sunshine to that problematic use of artificial intelligence to deny care, which is what it really is.
Yeah. And Dr. Parabati, how do you see these transparency laws that, Peggy just mentioned, shining that light on those algorithms and other types of metrics affecting your work and practice as a physician?
I think transparency as it relates to the given payer's performance, prior authorization performance, so the volume of requests, the number of denials, all of the things that are in the sort of public reporting component of this are very helpful to me. I mean, my practice in this way is a little bit abnormal in the sense that I do regularly have conversations with patients about the implications of their insurance coverage. And I explain these things to people, about the differences in traditional Medicare and Medicare Advantage, and into what to look into to select when they're open enrollment again and things like that. I take that time because I know something about this. And so perhaps my answer is not that generalizable to the larger physician population, but the more transparency there is on what patients are actually getting, so that their Medicare Advantage doesn't end up being, as people often quip, Medicare disadvantage, is huge when selecting their coverage. Otherwise, another component of this that I don't think we shouldn't overlook is that the rule emphasizes the larger initiative of the federal government, which is the plain language guidelines, so that people are presented with documentation that is, if I don't recall, maybe Peggy can inform me, or maybe Anna knows, what is the reading level or characteristics of this plain language. But this is another important thing. We talk about AI, we talk about algorithm, but we have to have a level of language that a person who's not deeply expert in these materials can readily digest, let's say. So those are two things that come to mind immediately. I'm sure I'm leaving something out, but I'll leave some space to the others for comment.
Yeah, that's so important. I'm glad you brought that up. I mean, in circles I'm in with just friends who are saying, how do I manage this? And how do I manage this in my healthcare? And I can't get this answer. And we're health policy experts, and we're having trouble doing this. That's insane. The average person, maybe with a 6th to 8th grade reading level, they stop trying. They don't have the time. If they're working a full day's work and going home and they're beat, they stop trying. And that's what the insurance companies are counting on, that those type of people just won't pursue the care, or the doctors are too busy to pursue the care for them. And that's an injustice in my mind.
Yeah. So we talked about, the memo talked about algorithms, and I heard Peggy mention AI. So we know there is a lot of discussion around AI in healthcare right now, including utilization management. Excuse me. Anna, I wanted to ask you, what concerns or considerations are you hearing from patients and patient advocate communities about the use of AI in healthcare? And how do you see patients utilizing AI?
Well, I think it's relatively new. We've had some recent conversations with patients and have asked some of these kinds of questions. I think one big takeaway for me is that there needs to be more education about what really AI is, because if you ask a patient, do you use AI or how do you use AI? The first thing that they're going to say, granted, this is not a huge sample size, but take that for what it is. They associate AI with ChatGPT,
Mhm.
as opposed to, yes, that's one piece, but there's also AI enabled technology, remote therapeutic monitoring technologies, and other things. And of course, on the administrative side that payers may be using, like we're talking about here. So AI covers a wide range of things. And I think we need to think about ways to sort of educate patients more comprehensively about what that means. So that's kind of one piece. When you start to drill down into that, I think that some of the concerns are accuracy of whatever AI kind of generates. And then privacy, data privacy is another piece. But one thing that I thought was interesting when we did a patient panel on this very recently is that one of our patients used ChatGPT to generate a prior auth letter, appeal letter for a denial, which I thought was very clever. It's like, okay, that's interesting. You can kind of fight fire with fire. So maybe that's another avenue that we can sort of explore a little bit more.
Yeah, for sure. Dr. Parvai, what do you think physicians, payers, and administrators will need to consider as it relates to patients' perceptions and attitudes towards this technology?
Yeah, I mean, I think Anna hit on a lot of key pieces there. She hit on the education and communication piece, because a lot of people have very little familiarity with AI. She talked about the data privacy and security. I think patients need absolutely robust assurances that their highly sensitive medical information will be protected and used in accordance, obviously, with all appropriate laws and their consent, of course. And another one I would say is the bias piece, because AI ultimately it comes from human produced writing, human produced pieces in various media that are out there. And so to the extent that we are biased, and of course we all are, that bias will translate into the AI. And so I think we need to think about, I don't know, I haven't prepared any particular thoughts on this, but proactive efforts to identify and kind of mitigate these biases as it relates to the use of AI in UM. Sorry about that, to AI and UM, to really protect patient equity and avoid exacerbating the disparities that we see ingrained in healthcare in virtually every setting. So that's
No,
what I would say.
I think you're spot on. And Cancer Support Community, our Research and Training Institute, actually launched a survey last year, I believe, to get patients' perceptions, cancer patient perceptions about the use of AI. And of the results we've received so far, what we really want to dig into is make sure is that we understand patient perceptions and that what any of those barriers are about AI or the information that is used to generate that AI, it doesn't exacerbate the inequities that you just talked about. I think even though you said you didn't really think about that answer, I think you hit it spot on. I think that's a very important piece and will probably be a topic of a lot of conversations as we talk about AI as it continues to grow, advance, develop in healthcare and in general more broadly. So I do want to leave some time for Q&A, but I do have one more question I'd like to open up to the group. We talked about a lot today with respect to prior auth and the CMS changes, some work we're hearing about in the States. But if you could make one policy change, I'll start with you, Peggy, at the state or federal level to positively impact the PA process for patients, what would it be?
Well, I'll start by being a little pithy, which is if an agency says that a change in law will save money, the CBO shouldn't be allowed to say the opposite. Because the expertise at CMS, when they put their rules together, they realize that everything we're talking about right now should save taxpayers, the system, money, doing it right, doing it better, getting people the care they need and not having the care delivered in the emergency room, which is the inappropriate place. Again, I'm being a little facetious, but that has been really frustrating. And also that Congress would hurry up and do this. It's a tough year and not much happens towards the end of this year. And we're hopeful that we won't get anybody putting any holds or opposition on this bill. And we need everybody's help to talk to Congress to get this moving. Oh, and by the way, in just a week of dropping a draft bill, we have 200, nearly 200 endorsing organizations again, that fast.
That fast. Absolutely. I'm not surprised. I'm not surprised. Dr. Parvati, any one policy change at the state or federal level?
Just if I have to pick one, I'm a big fan of gold carding, and I think that comes from my experience and the kind of system that I practiced in my career. We seldom ultimately receive denials. I talked about it when we had a preparation call. Whenever we do get upfront denials, we have dozens and dozens of appeals, and every single one of the appeals that our group has filed has resulted in overturning of the initial denial. But it introduced delays, it introduced stress for the patient. Why go through all of that? And with physicians and with everyone, let's face it, there's opportunity cost. The more time I'm spending doing that stuff, the less time I'm spending at the bedside or on the phone and talking about test results with my patients or whatever it might be. So it's just a deleterious part of the weekly work that physicians are doing, and hopefully we can find a way to get past it. Thank you.
All right. Anna, you have the last word to round us out before we go to Q&A.
Well, we need to add prescription drugs and apply it across all markets.
Simple. I love that. So I want to thank you all, the panelists, for this excellent discussion. And now I'd like to open it up to the attendees to ask questions. Before we do, we have a second polling question that I'd like to pull up and get your reaction to what you've heard so far. So we're just going to pull up that second question. Overall, do you think CMS's finalized policies on prior auth will improve, no change, or reduce? We'll give you all some time to respond.
It's a test of how hopeful people are.
Yeah. All right. So I'm improved. That's great. I think that's positive, especially that information that's coming down the pike in the next day or so. So I'm going to go to the Q&A and see if we have any open questions. I don't see any right now, but I'm going to check the chat just to make sure I didn't miss any.
And while you're looking, I'd just say we have a website, regrelief, regrelief.org. If you want to learn anything more about the bill I talked about today, or the regulatory processes or the rules, or all of the work that's gone into this by the 8 leads on the bill and everything else, it's all there. So
I think that's great.
regrelief.org, check it out.
Yeah, so I don't see any questions in the chat, which makes me think we must have done a phenomenal job discussing this issue. And so what I will do, again, thank you all for participating in our panel discussion. Thank you to the attendees, and we will follow up with the webinar recording and some links to additional information, the website that Peggy just mentioned, that bill information once it is available, and any other resources that we identified that we think might be helpful to all of you. So thank you all for taking the time, and stay tuned. We will be having our second Roundtable series coming up in September. So stay tuned for more information about that. So with that, I will let you go. Have a wonderful day, and we'll be in touch. Thank you.
Thanks for having us.